I want to introduce somebody that also many of you already met, and it's Dr. Leela Raju. Dr. Raju is a fantastic ophthalmologist. She's an associate professor, and she's also the chief of ophthalmology at Bellevue Hospital. She's a cornea expert, and I just want to show you something about her. Interestingly, Leela was found or named as the young doctor to watch by Millennial Eye, which is this big group in ophthalmology. And in that initial article, I also learned something I didn't know, was that her father, I guess is sort of common in ophthalmology. I know Carlos Mendoza is the same story. Her father, Leela's father, was also an ophthalmologist. So I think that ophthalmology is a dominant genetic disease. If your father has it, you are going to have it. That's what happened with Leela. She went to medical school at Marshall University, and also another interesting thing, aside from being an incredible superb ophthalmologist, she also played tennis, varsity tennis in the Ivy League, and she was a champion. I think she still is. So if anybody is ready, you could challenge her. A year later, after being named the person to watch, she was also named in this big prize sponsored by Novartis as the outstanding female leader in ophthalmology. Of course, Leela would be a leader independent of being female or male or anything. She's just an incredible ophthalmologist. We are lucky to have her, and she agreed to talk to you briefly this morning and tell you some of the things she's doing with FD.
I'm going to have to be better about finding out what's on the internet. Joking aside, I was chief at Bellevue until about a year ago, so I have to correct that too. But I think the nice thing, Bellevue is, I think as Dr. Glickman probably knows, is it takes a lot of your time in many ways. But the nice thing is it's allowed me to do a little bit more with the FD Center, which has been great. And I want to thank them for giving me the opportunity to tell you about some of the things that we can do to help make sure that the corneas, the vision stays as protected as possible, to make sure that we take that out of the equation of all the other things that the FD patients do have to learn to deal with. We sometimes forget what dry eye does to the cornea. It's not a simple matter of not having tears. It's also because when you don't have tears, the feedback loop that already doesn't work well in a lot of FD patients becomes even more affected, because those nerves are what tell the brain that, hey, you even need to blink. So if you don't have the kinds of quality tears to protect the eye, then on top of that, the patient is not blinking or unable to recognize when the eye does have a scratch. That's when you get those problems, as many of you I know have probably already dealt with or seen, that you now get a scratch that doesn't heal, and then the eye takes over and tries to do everything it can for itself, which often causes scarring on the cornea and also blood vessels growing in to the clear front part of the eye, which is not supposed to have anything like that. So it's a lot of this, and what I'm going to keep pushing regarding care of the eyes is prevention, recognizing that someone's not blinking very much, or that, and we already know that they're not going to feel the pain from a scratch. Scratches should feel like someone is really doing something really terrible to your eye, like that hot poker cliche. But if you don't feel that, then obviously those nerves are not telling the brain that there's something going on. So recognizing that that's the case, doing whatever we can to make sure that the tears can, or that something can be there to protect the eye when the tears can't, such as something like punctal cautery, or there's something called punctal plugs. Now that's not affecting where the tears come from, that's affecting where they drain. So even doing that temporarily in a case where there is a scratch that's having a hard time healing can help. Sometimes we should probably do that proactively in a lot of these patients to make sure that whatever tears are there at least stay on the surface and protect the eye. patients often don't realize there's other viruses that are very common. The cold sore virus, which it's very common in the population, so that's the one, that's HSV or herpetic disease type 1, can also affect these nerves and affect the body's ability to recognize that there's a scratch on the eye, or those nerves don't work the same way. So understanding that there are other things on top of just the eye being dry that we have to take into account. Some people may have also had an instance where someone had suggested doing an amniotic membrane. So these membranes are actually what protect a baby while it's developing, and they have no correction with any kind of abortive procedure. This is just tissue that is taken and cultured after a completely normal delivery. And that membrane, though, has amazing growth factors that help the cornea heal up. So not only can we do that as a membrane, but there's also drops that can be made out of these that material that have also been shown to help heal up a cornea when it has been damaged or has a scratch. And then, of course, sometimes we do have to go to the point where we put a little stitch temporarily in the eyelids themselves, because we already know that the lids are not going to blink and help spread tears across that surface that's damaged. So sometimes we have to help out the eye and at least temporarily close it. Now, the scleral lenses, and I've met a number of patients that are already using the PROS lens, which is one type, and that's based out of Boston. So it's required a lot of effort on on behalf of the family and the patient to go there periodically for fittings and making sure the lenses are clean. But there are other options, and I'm very lucky that I have a optometrist that I work with at our department who fits these. So PROS lenses are a great option, but it's only one of many kinds of scleral lenses, which essentially, as you see in that picture, because like normal contacts sit on the surface of the eye, these do not. They actually vault over the entire cornea. So that means that there can be a layer of fluid between the cornea and the contact, which is keeping it bathed in whatever tears you're putting in. Sometimes you have to refill it using artificial tears, but the possibility of keeping it protected, and once again, it's all about prevention. How do we avoid the cornea from getting damaged in the first place? And I mentioned the amniotic membrane. There's also drops that can be made out of this, and some people have actually also tried serum tears, and Maria's been great. We've been working on a protocol maybe to help start getting them here. And also, I do know that there is a location in the city that can help us get them to you at your home. So if someone has questions, please let me know. But serum tears or the amniotic membrane extract eye drops, while they are not particularly FDA approved, I have used them for many years, and I think the changes they make to those corneal nerves, even ones that don't send good signals, anything they can do to help protect those little nerve endings that are there, and also these are much more similar to our natural tears. The artificial tears are great, and we're very lucky to have them, but serum tears are definitely closer to what the components of our natural tears. But as I mentioned, sometimes just protecting the surface isn't enough, and it has to be reconstructed or recreated. I do a lot of work with people that have actually suffered trauma that led to a lot of these problems, where the nerves get damaged or the cells that heal up the surface get damaged repeatedly. And the reason we need to protect the surface is because right at the edge of the cornea, there's an area called the limbus. That's where those corneal stem cells are. Just like if you get a scratch, the skin will heal over that area. It may look a little different, but then it smooths out and looks like your normal skin. The same thing can happen to the cornea. But if you damage the cells in this area repeatedly, which dry eye or multiple infections or abrasions, scratches can do, then you need to make sure that this area is still healthy, because it may not be working as efficiently as it once did. We can actually image where these cells are. This is courtesy of one of my colleagues when I was at the University of Pittsburgh. I was there before I was at NYU, and you can actually tell where those cells are coming from and what we need to do to find the area that we need to protect the most. So as I mentioned, these corneal stem cells failure of them one of the reasons can be exposure. And so, and even here I rate contact lenses, but this is contact lens overuse from an eye that's completely normal, and then somebody's not taking out their contacts as much as they should be, so it's a slightly different issue here. These are not the same kind of contacts. But exposure is really what, in this case, might start hurting that cornea long term. So what happens is that as the cornea can't heal itself up, you can see that little picture, it almost looks like a boot there, where the cells have tried to heal up the scratch over and over again. And you can imagine when this doesn't happen and it remains a scratch, that's when you start getting blood vessels coming into the cornea and scarring. Sometimes this is from an alkali injury. Essentially, someone got cement in the eye. But you can imagine the eye will do whatever it can to protect itself. But through multiple modalities, it's never going to be just one, and prevention as much as possible. We can make these corneas look clearer again. And once again, it's all about prevention, I think, in the case of the FD patient. There are other ways. Let's say there is scarring to the point where it's affecting the vision enough. We can replace the cornea. Sometimes in patients that don't have great tears, a regular cornea transplant may not be the best way to go, but things like the keratoprosthesis was actually a partial plastic and partial cornea, actual cornea tissue can be used because that one area, that central area will never get hazy. Now, once again, it's not going to negate the issue of the dryness in an FD patient, but there are multiple options of what we can do to help clear up the cornea. So some of the new modalities that I'm very excited about, obviously it's very easy to say, hey, go put in these eye drops every 2 hours, but I realize, and you obviously realize how hard that is either for you or if you're helping out your family member, how hard it would be for them to continually remember to do that. So there are some slow release preparations of medications that are hopefully going to be coming out more frequently now. Some of the work that they've done already, that Dr. Kaufman's done at the FD Center regarding medications that help improve the production of tears is something we might be able to adapt to this kind of modality so that you're not having to put in drops repeatedly or come in for procedures repeatedly. One of the newer medications that is now FDA approved is something called Serum. It's a recombinant human nerve growth factor. And once again, it's all about protecting the nerves to this cornea. Even if the nerves don't function well, anything we can do to support them, make sure scratches heal up, means that that's time where the cornea doesn't think it needs to create scarring or new blood vessels in order to protect itself. And neurotrophic keratitis is what happens in an FD patient because the nerves that are supposed to be telling the brain and the eyelids and everything else that, hey, you need to protect me, don't work. And that's why they don't really feel that sensation of a scratch or if something's in the eye. Right, I'm just going to stop there. I have, I think, a few minutes for questions because unfortunately I might not be able to stay in the afternoon, but I'm happy to take anything, and thank you again for your attention. Yes?
How is that medication?
The Serum?
Yeah,
it's a drop. Mm-hmm. It's about a 6 times a day course for about 8 weeks. And then what they found is the ability to have the scratches or the surface to stay healed for almost a year. The data has been really great. Now, these are patients that because of other issues have a very similar eye to patients with FD because those nerves don't work either. So I think in the patient that we're seeing this repeatedly, it's something that we're going to be able to make a real an incredible improvement in their surface. Yes?
So can I ask, when you say the nerves don't work, but
Mm-hmm.
the nerves are there, but so what's the NGF doing? I mean, the nerves are, I thought the nerves weren't there, but you're saying they're there but not functioning with the NGF.
So I've been doing something called aesthesiometry, where I'm actually checking the surface sensation. I think there's a real gamut of how much sensation based upon the phenotype of or how affected that patient is by FD. Now, that's actually one thing we were thinking about looking into is you can actually image these nerves using something called a confocal microscopy. That's what that picture was actually from. My guess, and I think that's something we still need to look into because it hasn't really been reviewed, is if there are some nerves there, even in a very severe case, and if you can even make those work a little better, that you would have some effect from it. But I don't think it's very clear as to what percentage of nerves are there, what's their function, versus actually saying there isn't anything, because it's not an easy image to even get. And I think there's probably a variability. I'm not sure it's an all or nothing scenario, but there's definitely a number of FD patients that have pretty impressive amount of sensation, regardless of what's gone on in the back of the eye. They do have sensation, so that tells me that those nerves are working, and anything we can do to protect them long term would be more helpful. Yes?
If somebody hasn't had a corneal abrasion to date, are any of these other types of drops helpful or beneficial in terms of being proactive?
Yes, absolutely. I think that's very important. The other one that I'm glad you brought that up is also we know the importance of CPAP and BiPAP in these patients, and putting in gel and making sure you use the CPAP and BiPAP are very important so that you don't have extra air blowing into the eyes. But protecting it even when you haven't had anything, I think is very important, because even patients that use CPAP and BiPAP that don't have any cornea issues will get dry often, and I really stress using some sort of thicker artificial tear gel when using it, but I think they definitely work together, and it's all about what you can do to prevent even that start of dryness, which can start hurting these nerves and start this process. Okay, great. Thank you very much.